The early TAVR trial. We know that current guidelines recommend clinical surveillance for patients with asymptomatic severe aortic stenosis and preserved left ventricular ejection fraction, with routine follow-up suggested every 6 to 12 months. Two small trials did evaluate younger patients with severe AS, demonstrating a benefit for early surgical AVR compared to clinical surveillance. To date, however, no trial has explored the strategy of early TAVR compared to guideline-indicated clinical surveillance. This study sought to determine the safety and effectiveness of a strategy of early intervention with TAVR compared to clinical surveillance in patients with asymptomatic severe AS. It was a prospective multi-center randomized controlled trial involving 75 centers, including 3 Canadian sites. All patients were asymptomatic, the vast majority of whom were confirmed by a negative treadmill stress test. 455 patients received the SAPIEN 3, or SAPIEN Ultra bioprosthetic aortic valve, and 446 patients underwent clinical surveillance. Median follow-up was 3.8 years. The primary outcome was a composite of all-cause death, any stroke, or unplanned cardiovascular hospitalization. Of note, cardiovascular hospitalization included aortic valve intervention in the surveillance arm. Key inclusion criteria included age over the age of 65, severe aortic stenosis with the parameters listed here, LVEF greater than 50%. Patients were asymptomatic based on a negative stress test and/or detailed clinical history, and they had low STS scores. Key exclusion included a Class 1 indication for surgical AVR, unsuitable anatomy for transfemoral TAVR, severe aortic or mitral regurgitation or moderate mitral stenosis, significant renal insufficiency, lung disease or severe pulmonary hypertension, pre-existing prosthetic valves, or an active COVID infection or previous diagnosis with sequelae. These are the baseline characteristics. The average age was 76 years of age, about 30% were female, 84% were deemed low risk as per the heart team, 90% were determined to be asymptomatic based on the treadmill stress test. The average KCCQ score was very good at approximately 94. The echo characteristics include an aortic valve area of 0.9 centimeters squared with a mean gradient of 46 to 47 millimeters of mercury, and the average ejection fraction was 67%. Here are the results. The composite endpoint of all-cause death, any stroke or unplanned cardiovascular hospitalization was reduced by 50% with the early TAVR arm compared to the clinical surveillance arm. The number needed to treat was only 6 at 2 years. Here are the primary endpoints broken down. There was no difference in mortality. There were numerically fewer strokes in the TAVR arm compared to the surveillance arm, but this was not statistically significant. The major difference was driven by unplanned cardiovascular hospitalization. There was pre-specified secondary endpoints. Early TAVR was superior in terms of quality of life and mortality together. The favorable health status outcome score was statistically significant. There was no difference in ejection fraction, atrial fibrillation, death, or disabling stroke. The mean time of conversion to TAVR in the surveillance arm was 11 months. 26% converted at 6 months, about half at 1 year, and 70% at 2 years. In other words, the majority of patients crossed over to the TAVR arm. Symptoms at the time of crossover to TAVR was shortness of breath 83% of the time. Of note, about 30% of patients develop NYHA class 3 or 4 heart failure symptoms. This slide essentially shows the procedural outcomes in the early TAVR group compared to those who underwent TAVR later on, demonstrating higher rates of complications such as need for pacemaker, strokes, or major bleeding for those who were converted to TAVR from the surveillance group. The authors conclude that in patients with asymptomatic severe aortic stenosis, a strategy of early TAVR compared to clinical surveillance resulted in a significant reduction of the primary endpoint, which is mostly driven by unplanned cardiovascular hospitalization, including those who converted to TAVR. This was not associated with an excess mortality or stroke. This strategy prevented a clinically meaningful decline in quality of life in clinical surveillance patients who subsequently converted to TAVR, and there was improvement in measures of LV and LA function.